Let me go ahead and share my screen. Okay. Everybody see? Are we good? Beautiful. All right, everybody. Well, as Lauren mentioned, I'm going to be talking about breast cancer survivorship today and sex, and I'm going to really focus on utilizing the sexual tipping point model for positive therapeutic outcomes. So, the sexual tipping point model, and I'll get into this, is a model that I think is really great for a lot of different providers, which is why I like to present on it. I think it's really applicable to a lot of different practices. It's not just for doctors, it's not just for therapists, it's for nurses, it's for really anybody that's involved in any level of care, case managers. So I think it's a really great model, and that's kind of why I chose this to be the Echo talk for today. So just a little bit about me. And I know I mentioned this, the only sex therapist at WVU Medicine. I have been since August 2020. I'm board certified as a nationally certified counselor, and I'm dual certified as a sex therapist with the American Association of Sexuality Educators, Counselors, and Therapists, and the International Board of Sexuality Professionals. And I'm actually the only dual certified sex therapist in the state of West Virginia at this time. Some fun facts about me that I always like to give are that I'm a lover of cooking, Walt Disney World, and shopping, as evidenced by my coffee mug here today. So, um, what I'm going to do is kind of present a little bit a different, I think a different approach than what everybody is used to. I know that sex is not always something that we hear a lot about or that we have a lot of education about. So I'm going to try my best to make this as approachable to all of you as possible. So I really do encourage questions. I'm really hopeful that everybody will have some great things for me here towards the end. So just kind of keep that in mind as we kind of move forward here. So I just kind of wanted to highlight the importance of mental health treatment, specifically in cancer survivorship and care. So roughly 1/3 of patients with a cancer diagnosis will be diagnosed with a occurring mental health diagnosis requiring treatment. And between 40 to 90% of those patients do not receive mental health treatment during, before, or after their diagnosis. And I think those are really sad statistics because not only are we talking about lifelong implications, health implications from having cancer, but we're also talking about the mental health aspect of that as well. And we know that mental health is physical health, and such a large gap of this is not always being treated for these patients or for this population. And the other thing that we know is that survivorship outcomes are multifactorial, but they are impacted by mental health treatment. So a lot of what we see is that people that have that mental health treatment or that mental health care will have better outcomes when it comes to their cancer care. And we will sometimes see a reduced positive outcome for those patients that don't have mental health treatment. And so this is a case study that I'm hoping we can kind of keep in mind. So I'm presenting it a little bit earlier. I know that we mentioned that we would do kind of a case study as part of that. So this is one that I want you to just keep. This is an actual patient that I had. Names obviously changed, but this is a patient that I've had that I worked with and was able to kind of see through her full treatment. So Sarah was a 45-year-old woman who was diagnosed with breast cancer 2 years ago. She underwent a mastectomy followed by chemotherapy and radiation therapy. She is currently prescribed an aromatase inhibitor throughout her treatment. Sarah experienced significant physical and emotional challenges, including fatigue, anxiety, and body image issues. Now, as she transitions into survivorship, Sarah finds herself struggling with intimacy and sexuality in her relationship with her husband, Mark. So just keep Sarah and Mark in our thoughts as we're kind of navigating the rest of the presentation. So sex is a biological function. Do we control how our lungs exchange oxygen? Do we control how our digestive system functions? Do we control how our heart pumps? My hope is that all of you in your head are answering no to all of those questions. We do not control those things. And so when we're looking at not being able to control sex and not being able to control our sexual interest, our sexual desire, all of that is going to be impacted by the extenuating circumstances that we're surrounded by, our environment, our biological functions that are, other biological functions that are going on. So those are not things that are within our control. Can we control arousal and orgasm? No. So again, those things are two things that we truly do not control within our bodies. Our bodies regulate those things on their own. And again, those factors that play into that are going to either increase sexual arousal and likelihood of orgasm or decrease sexual arousal and orgasm. So when we're talking about controlling the stimuli that we put into the system, these are things like medications, like different types of touch, like intimacy with partners, like sexual toys, those kinds of things. So when we adjust the stimuli, we can increase the likelihood of those things happening, but we cannot guarantee or control those things. And so when we look at the sexual tipping point model, it easily explains why patients are experiencing sexual dysfunction in a clear and concise manner. So the hope is that when you sit down in front of a patient, you can kind of give them a really, really clear explanation of, hey, this is what's going on. This is why this might not be something that's in your control. Here are maybe some things that we can do to help. And again, as I mentioned earlier, this is adaptable to all types of medical practice. And I think that's such a huge benefit of the sexual tipping point model is that we are not just saying, oh, well, therapists can use this and we don't have any other control as other types of providers. We actually do. And I think that's why it's such a great model. So a little bit on the background of the sexual tipping point model. It was originally researched by Helen Kaplan, who was really well known for her multidisciplinary approach that she took to sexual dysfunction. She was one of the first people to kind of pull in therapists and psychiatry and other types of people in medicine to really kind of try to get that approach where we're treating the entire person and not just one aspect of the person. And so when her research really kind of started to take off, she said, well, we have to find a way to make people understand as quickly as possible that these are not always things that are in their control and how do we do that? And so the sexual tipping point was the outcome of that. Now, she did not actually get to see that through. Her colleagues actually finished this for her. And because she was a sex therapist, she made it originally for sex therapists. But I think the beautiful thing is that we have generalized it to all sexual medicine and general medicine over the years. And so what it really does is it evaluates both those inter and intrapersonal factors in a biopsychosocial cultural perspective, making it inclusive to pretty much all populations. So the model breaks down further the mind-body connection to easily demonstrate how both mental and physical factors can affect arousal and desire. And the model also helps providers and patients evaluate arousal and desire and the stimuli that are currently affecting the system, leading to the sexual dysfunction and what those dysfunction factors might be. So I have a infographic here of what the model actually looks like. And I encourage providers to kind of see this. I'm hoping you'll have access to the presentation after, not only through the recording, but I'm happy to send it on to you too if you would like it, to really be able to review this on your own time as well. But what you notice on either side, right? It is a tipping point, right? There's the same things on either side of that can either excite or inhibit. And so when we're talking about all of those factors, we really are talking about the scale that one thing can shift or can change that would inhibit that sexual functioning. And one thing can shift and change that would excite that sexual functioning and make it more likely for those things to happen. So I think this is something that you really can put in front of a patient and say, all of these factors are going to be what's affecting why you're feeling the way that you do right now. So when we're looking at using the model, and I think when we mention combination therapy, this is kind of the hallmark of what we're talking about when we're trying to pull all of these factors in and when we're utilizing the model to explain different things. So in the 1990s, providers began combining medication with cognitive behavioral therapy, and that's kind of really where we started to see this combination therapy in the mental health field really start to take off. And in the early 2000s, we really began combining pharmaceuticals and sex therapy for better optimized care. So for a long time, we had Viagra and we had those other things, but we really started to see kind of more towards the early 2000s, some things starting to come out for other populations, not just for men, that were able to try to help increase sexual functioning. And so we started to see some of that change. And those are more things like SNRIs, that kind of stuff. Nowadays, we have a lot of different options for combination therapy. We have things like Addyi and Vyleesi. Addyi is a pill and Vyleesi is an injectable. It's, varied for a lot of different people, but we are starting to see more options for the female population specifically. And I think that's what's really, really exciting about that. So we're starting to see some of these things change, and I think that's good. So when we talk about the oral therapy of choice, the sexual tipping point model creation team really kind of said that combination therapy is really ideal for that. And that's what we're looking at when we're trying to treat kind of the whole person. And then again, that's what the model tries to do. So sexual dysfunction at the end of the day always has a psychological piece, even if there is illness, physical complications, or treatment of illness. Sexual functioning in itself inherently does, when we're talking about arousal, have some level where the brain has to be able to make those connections. So when we're talking about arousal being able to be something in sexual dysfunction occurring with that psychological piece, it's inherent that we're going to have that little bit of push and pull of those things fighting against each other. So when we look at pharmaceutical interventions and sex therapy being combined, the more severe the sexual dysfunction presents, the more beneficial pharmaceutical intervention can be. And this is also broadened to, I think, general mental health wellness. We will see time and time again, every research is going to show you that if we combine medication and therapy, we're going to see the best positive therapeutic outcomes and the betterment of that patient. So it's really the gold standard. It's really the ideal. And I think most therapists are super stoked when we have a person that is willing to use medication and to then also go through the therapy process to kind of have both of those things together. So, and again, as I mentioned, those things can be effective on their own, but I think we really see the most positive outcomes when we combine those two things. So what diagnosis is the sexual tipping point model for? Well, the good news is it's for every and any. There's not a one-size-fits-all plan for any patient or diagnosis, but the sexual tipping point model is really able to be applicable to pretty much everyone. So when we're looking at different types of diagnoses, different types of cancer, different types of survivorship, palliative care, whatever we're looking at, it can be applicable to those patients. Multidisciplinary factors versus understanding is always going to be really important, because when we're using this model too, we also have to take into account what is this person's functioning like outside of sexual functioning. So is this person able to walk? Is this person able to talk? Can they give verbal consent? Can they do these things? Do they have a partner? All of those things play a role into the sexual tipping point model as well. And so keeping that in mind when we're explaining it to different types of people with different types of diagnoses is important as well. So in terms of some therapeutic interventions that are specific to sex therapy, we're looking at acceptance and commitment therapy, cognitive behavioral therapy, and mindfulness therapy. Now, these are just the three interventions that I use specifically. There are others that other types of sex therapists use. These are my three favorites, and I will tell you a little bit about why. Acceptance and commitment therapy is really beneficial in cancer care in general, because it's looking at it basically saying, okay, you're in this space might not change. Let's commit to helping you manage or work through it. And so that piece, I think, especially for people that are in chronic pain or experiencing chronic treatment, is a really, really great space for people to kind of work in. And so I really love acceptance and commitment therapy for that reason. Cognitive behavioral therapy is really the hot button therapy right now that most people are doing. And that's basically bridging the gap between the mind-body connection and behaviors that we engage in. So when we look at cognitive behavioral therapy, it's a lot of tools, it's a lot of skills, it's a lot of kind of trying to reframe things back to people, and it's also really great for cancer care as well. And then mindfulness therapy is really where you're going to see a lot of the sex therapy interventions come in. Things like sensate focus that I'll mention a little bit later on are really, really important to the mindfulness-based approach. We can't do it without someone's willingness to be a little bit open to kind of feeling their body and understanding and recognizing different sensations and what does that look like. So mindfulness is a really big role for that as well. And so with sensate focus, it's a technique often used in sex therapy and couples counseling to help individuals or partners increase intimacy, improve sexual communication. So this was originally developed by Masters and Johnson in the 1960s, and sensate focus involves a series of structured exercises designed to enhance sensory awareness and intimacy between partners without the pressure of performance of goal-oriented sex. So when we're looking at what Masters and Johnson did for us, they basically kind of started a space where we were doing sex retreats and they were doing couples retreats for people. And so it was really in a bubble. What we see now and what research has kind of been able to do for us, and what some of the people that actually originally worked with Masters and Johnson have done, is rewritten a lot of those rules and a lot of those functioning, so that when we look at the exercises themselves now, they can be applicable to a lot more of a wide range of people. And so I would say that sensate focus is probably the sex therapy technique that I do the most. And it's really the technique that I use a lot with my cancer patients, because when we look at how much the body changes, we talk about like neuropathy, we talk about surgery, scarring, pain that people experience. That's inherently going to change our sexual functioning, and that's inherently going to make things very different from what things were like prior to cancer. And so when we're looking at what Sensate Focus can do, is it really kind of, it's almost like hitting the sexual reset button and giving people an opportunity to relearn what can be comfortable for them without the expectation that sexual arousal has to happen. And I think that it's a technique that takes a lot of time to get through, but is really my personal favorite to guide patients and partners through. So when we look at the touching within Sensate Focus, it's not to establish a sexual arousal or to do really anything sexual. It's to establish an awareness of sensations by noticing textures, temperatures, and contours while doing the touching, or to simply be aware of the sensations of being touched by their partner. Texture, temperature, and pressure are key points, and all other sensations and senses are important as well. But it's a lot of really directed focus so that people don't get into that sexual realm. And again, I think it really creates that space where people can learn their bodies a little bit better and understand what's comfortable and what is not. So when we're looking at the application of the sexual tipping point model in the case study, so we're going to bring back Sarah and Mark and talk a little bit about how I would approach this case with the sexual tipping point model. So the biological factors that are at play. Sarah experiences physical changes as a result of her breast cancer treatment, including decreased libido due to hormonal fluctuations and vaginal dryness caused by aromatase inhibitor use and chemotherapy-induced menopause. The psychological factors that are at play. Sarah grapples with body image concerns following her mastectomy, feeling self-conscious about her altered appearance and fearing rejection from her husband. She experiences anxiety and intrusive thoughts related to her cancer experience, which disrupt her ability to relax and enjoy sexual intimacy. The contextual factors. Sarah and Mark's relationship dynamic has shifted since her diagnosis, with a newfound focus on caregiving and coping with the challenges of cancer treatment. They struggle to communicate openly about their sexual needs and desires, leading to feelings of frustration and disconnection. So what are we going to do? Sarah's obviously struggling. Her and Mark are both not really sure how to navigate their sexual relationship after her cancer diagnosis. And the shift that they experienced in their relationship was one from being a partner to a more caretaking role. And that shift in itself, trying to get that back, is really, I think, where we're going to talk about why enhancing emotional intimacy is so important when it comes to sexual functioning. So the therapist will facilitate open and honest communication between Sarah and Mark, encouraging them to express their fears, desires, and concerns related to intimacy and sexuality. The couple engages in activities to strengthen emotional connection outside of the bedroom, such as sharing feelings through journaling or participating in couples therapy sessions focusing on emotional intimacy. So when we talk about emotional intimacy, I think it is one of the things that I hear most from my cancer patients say. I feel so disconnected from my partner because so much of what we were doing was just me getting through cancer. It was just me trying to survive cancer, and the lack of parenting, and child rearing, and trying to also then be in that romantic relationship where you're managing things like finances, you're managing things like your career, you're trying to find all of those balances without a cancer diagnosis is hard. Tack in a cancer diagnosis where you're fatigued, you're in pain, you're struggling in 1,000 other different areas, you've got 50,000 appointments, your time management skills are not what they used to be, right? It can really lead to the degradation of relationships. And so when we talk about enhancing emotional intimacy, I would say it's honestly one of the biggest hallmarks of care, and one of the biggest things we need to address when it comes to increasing sexual functioning or bringing sexual functioning back after cancer. And so when we're looking at building those sexual skills back, because again, for a lot of the patients that I work with, sex wasn't necessarily happening while they were going through treatment. And if it was very different from what they were used to before. It might have been some different levels of touching. A lot of people, I think a lot of heterosexual couples specifically, penetration is one of the first things that goes off the table for a lot of people because it's just so uncomfortable. And then for other different types of couples in the LGBTQI plus community, I think you also see penetration in different types of things go off the table because that discomfort is there too. So that can feel like a really big loss to a lot of people. So when we're talking about rebuilding those sexual skills, We're looking at providing education and guidance on techniques for enhancing sexual pleasure and intimacy. We're talking about sensate focus or other mindfulness-based approaches to intimacy. And then with Sarah and Mark, they're going to explore alternative forms of sexual expression and intimacy that accommodate Sarah's physical changes and limitations. In this case example, there was no reconstruction done. That was a choice that my patient made, that this patient made. And navigating what do you do when breasts are gone was a really big deal because breasts were such a big part of their sexual experience before. And when that's a whole chunk of you that's gone and your feeling is different and you have scar tissue and it's not the same, well, what do you do? What does sex look like for you then? So those shifts and those changes that we talk about when we're looking at how do we change sex and what changes with sex and how can it still be enjoyable and pleasurable is another really big part of navigating what sexual skills can look like after cancer. So when we look at that self-esteem, as I was kind of talking about the loss of Sarah's breast specifically, we help Sarah challenge negative beliefs about her body and sexuality, and we emphasize her resilience and strength as a breast cancer survivor. Sarah engages in self-care practices to nurture her sense of femininity and sexual confidence, such as attending support groups for breast cancer survivors or practicing positive affirmations. So what happened for Sarah and Mark? Through ongoing sexual therapy sessions and dedicated practice of strategies informed by the sexual tipping point model, Sarah experiences a gradual improvement in her sexual well-being and relationship satisfaction. Sarah and Mark develop a deeper understanding of each other's needs and desires, fostering greater emotional intimacy and connection. While challenges may still arise, Sarah feels empowered to navigate them with resilience and self-compassion, embracing her identity as a breast cancer survivor and sexual being. And so I think when we're really looking at what these therapeutic outcomes can be, this is obviously a perfect case scenario. It was a beautiful case. It went perfectly. Everything kind of came out, but that doesn't always happen. That doesn't always happen for people. Sometimes sexual functioning never returns to what we want it to be. Sometimes sexual functioning never comes back at all. And so what do those cases look like? They're challenging. Number one, it's a lot of grief and loss work. It's a lot of management. And that's something that I'm happy to discuss too if anybody has any questions about that. What does it look like when cases don't go perfectly? So what can you all do that are non-sex therapy providers? What can you do? What questions can you ask? What things can you kind of ebb and flow and change to bring into your practice to use the sexual tipping point model to kind of engage the work that you do? You can touch base on some of these things, and I really love this infographic because I think it gives really explicit examples that you can pull right into your practice. You can ask a couple questions, and sometimes it's as simple as, have you noticed your interest in sex change? That can open a door for a lot of people to talk a little bit about different things. Are you worried about any of your other general health issues or other things kind of coming up outside of your cancer that we're maybe not managing or that are different? So you can always ask a couple questions about that. You can always ask some more about the practices and behaviors, which is taking a little bit more of a deeper dive for sure. But how is your relationship with your partner? Any concerns about intimacy? That can be such a really great one that just is, it's right on the cusp. Are you having any issues? And sometimes all people will say is yes or no. And that yes or no can really open a door for you to kind of ask some of these other further questions, like, have you noticed any of these difficulties? Are you experiencing any of these things? So sometimes just getting yourself in a space where you feel like you can ask that one question, that door opening question, can really open up and broaden your space to be able to talk about sexual functioning with your cancer patients. And so what else can non-sex therapist providers do? It's not always your job to evaluate relationship dysfunction, but I think it's important to note that if there is relationship dysfunction present, medication and education alone will not be successful. There's no amount of therapy that we can do that will make sexual functioning come back if the relationship is in a space where the other partner is not willing to engage or to change. And so that is one thing that we can see if they're looking for that partnered sex or that partnered relationship where sexual functioning may never return, or it may not ever be able to be ideal, or what that other person might want it to be. So if you do identify those psychological factors, it doesn't mean that you have to treat them. You don't have to kind of get get into a space where you're not comfortable or practicing outside of your means. Referral is always an amazing option, but my biggest point when mentioning referrals is making sure that the patient is aware and agreeable to this referral, and making sure that they know what they are being referred to, not just putting that referral in the system and the patient getting a surprise on their my chart saying, oh, well, here's your, your appointment with the sex therapist, and then they come and talk to me and they're like, I don't know why I'm seeing you. And it's like, well, is this going on? So trying to have that conversation as much as you can. But again, I think the biggest thing that I can say to you is to practice to your level of comfort and ensure that, what you can do is your best with that. And so sometimes finding that one question that you can ask can be enough. So the key points of everything that I mentioned today here with the sexual tipping point model. This model helps providers and patients better understand what is affecting sexual function so that treatments can be presented in a clear and concise manner. Partner cooperation and support is absolutely needed when it comes to managing partnered sex. If it's solo sex, it's a lot easier to manage. But if a partner is involved, then it is needed for that person to be agreeable to engaging in the treatment. Psychoeducation for both the patient and partner is needed as well. When we talk about sex as a biological function, a lot of people are sometimes surprised. They're like, well, I should just be able to do it. And I'm like, well, yeah, if you were just able to do it, number one, you wouldn't be talking to me. And number two, everybody would just be doing it all the time. And we would have a lot of problems. I don't think we would get much done if we could just snap our fingers and do those things. But combination therapy is the gold standard of treatment. So we're really looking at medication and therapy combined being the absolute best option and outcomes for people. And sexual functioning and desire is a biological function. So those are not things that we can, again, snap our fingers and change. So those are just my references that are listed in there. Questions, concerns, anything that anybody wants to share or ask?
So I was wondering, what was that a real case of Sarah and Mark?
Mhm.
And
Yeah.
what happened exactly? And because
Mhm.
I'm sure that that's in after mastectomy or any kind of surgery, but
Mhm.
especially mastectomy. What happened with them, and how did things go? You
Yeah,
said
yeah.
it went really well, but
It did. I mean, it was like the perfect, I mean, they just worked so hard. They worked so hard together and they were such a beautiful couple to follow with because they did everything right. I'm like, you
oh
guys are the
God.
perfect patients. Yeah. But I actually had the opportunity. She was a referral from Megan Burkhart over in the and she's amazing and great and we love her, and she had sent her over because she had been having some pain residual after her mastectomy, and so I really didn't get to follow with her fully through her entire treatment and stuff, but what I did get to do was see her pretty soon after her mastectomy. So she was still kind of ongoing with some additional treatments after that, and she was already on her Arimidex and all those things. So um, they put the work in, and I think that is really the biggest thing when it comes to therapy is people have to be willing to put the work in. I mean, they came together as a couple, they took off work. I mean, there were times where it was really difficult
Oh,
for them, but we made it work to get them in weekly, which is really what they needed at that point in time. um, but yeah, they did so well because they wanted it. They wanted it so bad. And penetration actually didn't come back for them. It was something that was just really impossible. Um, Her tissues just really never got back to a place that we ideally would be able to welcome penetration back. It was just too painful. They tried really hard. But what we were able to do was rewrite what sexual functioning looks like for them. So their sex is different. And I use that a lot as an example for like more of my older patients when we're talking about sexual functioning, is that sometimes sex just becomes laying and cuddling naked, and that's okay too. So sex looks different for everybody. And I think that's the big thing for them is they were able to also be okay and accept that that wasn't something they were going to get back.
wow.
Yeah.
It's amazing.
Hmm.
Thanks for what you do. It's
Oh, thanks,
wonderful.
Lori. Yeah. Anita, yeah.
Hey, this is so good. I work in public health and I also do women's health. And so yes, we need more of you. And this is something that I think is just not talked about, just, whether it's cancer survivorship, but really just any care. This is something that's so important that we should be talking about. And so I guess my question for you is, number one, in a state where we have two licensed sex therapists and in a state where travel is a major barrier,
Mhm.
as well as, people are a long ways away, what strategies do you have to help in that situation? And then number two, how are you communicating then back and working kind of as a care team to coordinate with her oncologist or her healthcare
Mhm.
provider to say, like, these are the things we've done. I really think, this is what the feedback I'm getting regarding tissues and like you just talked about, and
Mhm.
can we try different things? So I'd love to hear what you're doing and how to enhance these services. Thank you.
Yeah, yeah, 100%. So, the beauty about being able to offer telemedicine now is that I see people across the state. The other provider that is a sex therapist that is actually a sex certified, he's down in Charleston and he has a very limited schedule. So it's really hard. And he is I think he's taking people right now, but his schedule is also very limited. I'm actively taking new patients, but I think the last time I talked to him, which was, to be honest, a year ago, he's a little hard to get a hold of. He wasn't actively taking, but I did look on his website actually a couple weeks ago, and he is now. So he is an option if people are down that way. His name is Jack Copley. He's a really nice person, but like I said, his availability isn't super great. Um, but yeah, so I offer telemedicine, and then when it comes to kind of working with our oncology team, it is a little bit more of a challenge, right? Everybody's spread so thin as it is. I think I have a background in, well, my dad's an OBGYN, which I think helps my understanding of some of those things as well. More
Can't hear you.
I think we lost her for,
Okay.
let's hope she comes back.
ah,
Oh, there you are.
am I back? Oh
You're
no.
back. Your dad is an OBGYN.
Yes, okay. My
Continue.
dad's an OBGYN. So a lot of those things, my background in kind of understanding and being able to kind of work in those realms, I think started from him. When you're like 10, going to your dad to work and like watching pap smears and pelvic exams, you kind of get into it pretty young. Um, but no, when it comes to collaboration, I really try to kind of talk to the oncologists as much as they need to kind of reach out to me. Sometimes they'll follow up and say, hey, we have this going on, or this is something that's changing. I used to have a really great multidisciplinary team over in the sexual medicine department. We had some really great providers that were there with us. I'm a party of one now, but we're trying really hard to get kind of some of those things back. But yeah, I'm always happy to do case consultation, and I do think I hear from some of our team, hey, is this what else can we do to kind of better this patient outcome? So I think it's really just the oncologist's ability to be open and available for that time too, because it's hard. It's hard to fit that in, but yeah.
Thanks, Elise, and thanks, Anita. We have a question in the chat from Aaron
Oh,
Williams. He's interested in hearing more about the grief processing aspect that you referenced and asked if you could expand on that.
yeah. So I see this with a lot of just in general levels of sexual functioning. We see it a lot for men in the sense when erections are a lot harder to obtain. And also then for women, again, when we have tissue changes or mastectomies, things like that. So grief and loss is not one thing that we always talk about when it comes to this type of stuff. But when we look at sexual functioning, we don't ever think that it's something that will go away entirely, right? It's this thing that we kind of always have. It's this thing that's around, but then one day it's just gone. And it's very similar to death, and it's very similar to those things of I have a mourning process that I have to go through because this functioning isn't the same that it was before. I have to understand and be willing to accept and commit, right, to those changes and know that this might not be something that I ever get back to that space, or this might not be something that I'm ever able to have the same way that I did before. And so when we talk about that, sometimes we'll really get into difficult conversations of like, I don't want to be in this space. I don't want to deal with not having these things anymore. I want this back. And it's challenging for a lot of people, and I will say that I have had patients that sometimes never get to that space. Um, and I have patients that I've seen for 3 and 4 years now that, you know, have been through cancer and are not having any sexual functioning and don't have the space or the mental capacity to be able to bring some of that back because they're just still so grieving what they had before. It's hard. It's very hard to process for a lot of people. But that's another one where it has to kind of be that mind over matter space of, okay, we can put our seatbelts on and really buckle ourselves in and deal with this, or we can kind of sit in that space where we're not 100% ready for that change, and we can spin our wheels in the mud for a long time when it comes to grief. And so I think it's a push and pull process for sure, but people have to want to get through it.
Anybody else? Oh yeah, go for it, Anita.
I have another question.
Mhm.
Some of the responses that I see in my patients are that, especially with survivorship,
Mm.
they're just so like a lot of times they just are like, well, I'm just so glad to be alive. And then there's this guilt and hesitation to
Mhm.
say, like, to acknowledge that grief because they're like, why am I feeling this way?
Mhm.
Because man, I'm just so lucky to be here. I'm so fortunate. I'm blessed, all the things. But really, like you said, like just sitting with it, how do you like from somebody that would be seeing someone kind of on that receiving end or like them coming back to
Mhm.
your care would be like my situation. Like, how do
Yeah.
you delve into that? That it's yes, we're thrilled that they're alive, but part of them is different and changed. And how do you acknowledge that and move forward? Um, because I think it is kind of the elephant in the room that nobody really wants to talk about. It's hard to
Mhm.
fit that in a 10 to 15 minute visit. Um
Oh.
and but also saying like, I see you and this is part of it too. So do you have any suggestions on that from that standpoint?
Mhm. Validate, validate, validate. Validation is your best friend when it comes to those things. Um, you are never going to be able to change that person's perspective in 10 or 15 minutes. There might be one or two things that you find that can let them know, you are not the only person that's experiencing this. You are not, you are not your diagnosis. It's individual. You are allowed 100% to feel the way that you do, and you should feel the way that you do. But the challenging part in that then becomes we can validate, validate, validate all day. But if that person is still stuck in that, like, this thing isn't better. I'm alive, but this thing isn't better. It is, I think it's really one of those spaces where people pick and choose what providers they can kind of release some of that information to, which means that you then get stuck in the space where you're trying to hold a lot of space for someone that you might not necessarily have the time to do. And that it's really hard to be in that position to not feel like you have enough time. Um, So my best recommendation would be to find some of those key points of like, this is normal. Here are the options that I can give for you. Here are the referral spaces that I can give for you. Here are the things that I can do. That is what you have in your power in your 10 to 15 minutes. You can validate and you can refer. And those are really, really empowering and strong spaces to have too, because that means that you are holding a lot of space for that person just in that chunk of time to say, I can help you in these ways. They still have to accept it. So,
Does anybody else have any questions or you can have a patient in mind as long as you don't use their name, obviously, but you can bring up a patient. I know we have some counselors on here. I I have a question, Elise. So, you mentioned you're the only dual certified, therapist, and there's just one other, certified sex therapist in the state. So
mhm.
that's a health access issue, right? It's a health equity issue. And I guess, do you have any suggestions for how we could try to go about increasing those numbers of, specialized therapists, certified therapists in the state?
Yeah. I think what's challenging about sex therapy is that it is not a topic that a lot of people are comfortable talking about. I remember when I said I sat in my grad school class and they were like, "What kind of therapist do you want to be?" Everyone's like addiction or like, art therapy, music, and I'm like sex, and people are just like, they kind of like look at you and they're like, "Oh God," like what's wrong with you? Um, but I think I am in that unique position, right? Because I grew up around sex. I grew up with pictures of hysterectomies on my kitchen table while my dad was doing paper charts, right? So there's like, my mom was a labor and delivery nurse. So I am someone that kind of came from a high level of comfort space with sex. And I think that's what's really hard is that it's still so taboo. Sexual functioning is still so taboo. And when we talk about people actually wanting to do the training to become dually certified, it's a long time. It took me 3 years to get my certifications, and there are not a lot of people that are willing to do that. I always akin it to my 3 years of additional training were like my residency, right? So I am fresh out of residency in that sense when it comes to looking at what certification looks like. And to be honest, there are people that aren't willing always to do that training, but I think sex therapy is a really up and coming field and more people are getting into it. The problem is there's so much money in private practice and there's so much money in a lot of other different areas. And I mean, I have colleagues that are making $500,000-$600,000 in private practice. And um, it's that's really, you have to have a passion and care for wanting to work with populations that don't necessarily have it. So I think that's the biggest gap. Um, it's financial, and academic medicine doesn't necessarily akin that. And when you're talking about a more rural state too, there's no infrastructure here. So I think we could expand the program, but you also have to have the space to where people want to expand the program. We've been recruiting for a sexual medicine specialist for 2 years, and no one wants to come. So
Thanks, Elise. You have another question in the chat.
yeah.
First, thanking you for everything you do. And then how do you navigate situations where your patient is putting in tons of effort and their partner or partners are not?
Oh, KP, thanks for your question. Kristen is one of our pelvic floor physical therapists that left. I have to give her, I know, she's the best. We miss her all the time. But yes, it is, I think, the most heart-wrenching space in practice when you have a patient that is coming in and they are just trying so hard and they are doing everything they can and their partner's not willing to come in. Their partner's not willing to do the exercises with them. Um, the provider I used to work with, her name was Dr. Enzela Kane, and she used to say, sometimes what a lot of our patients need is partnerectomies. And I think the growth and change that I've seen for some people when they either decide to end a relationship or leave a relationship it's life changing for a lot of people. But I think it can be very frustrating as a provider too. And I think that's a hard spot to be in when there's nothing more you can do. And you have to look at this person and say, you're doing everything that you can. I don't know what other options we have available if your partner isn't willing to kind of help engage. And it's an awful conversation. It's not fun. I've had to do it one too many times. But it's hard to navigate. Sometimes all you can do is hold space for that person and hope that they eventually find a space where they can either find something that works for them and their partner or the partner.
Thank you, Elise.
Yeah.
And these are great questions. Thank you all for being so engaged. Does anyone else have any questions, any comments, Elise?
We do love a partnerectomy and replacement. We love when they get the fresh new one in because we're like, yes, it's so exciting. And then you see them grow from their change. Like it's like they get a new partner, and then in like a month, they're having great, awesome sex, and you're like, what is that? It's so good. But
Yeah, I have another question. You talk a lot about like we're a rural state, we're a very conservative state. Like I don't think anyone in our legislature can say sex without like
Right.
feeling like they're sinning or something. I don't know. It's
Yeah.
just so My question is, do you think if we could change the dialogue related to, sex is a biologic phenomenon, even in like
Hmm.
schools and how we talk about sex, like you said, like with your families, like how do
Hmm.
you see that impacting women and partners and folks that are in this situation um now and then in the future if we can shift even from a preventative standpoint, like if we can
Yeah.
improve sex even before these life events, like,
Hmm.
so could you speak to that?
Yeah, it's funny that you bring that up, Anita. I actually, I am going to go back and get my PhD one of these days, guys. I don't know when, but I will. I'll do it at some point. Um, WVU took away the option that I wanted, so I have to do it somewhere else. But when it comes to talking about sexual education, it's so poor everywhere. There's not a state that it's great in. You can go to California and you can go, and it's still terrible. Um, the biggest problem with sexual education is so much of it has to come from home to an extent, right? Because sexual functioning and education is how do you grow up? Is it talked about? Is it something that you're aware of? Sexual functioning happens for kiddos. There's a reason 2 and 3 year olds. I mean, we are born sexual beings. We have these, this is a thing that we have all the time. That doesn't change. And so when we're looking at when that conversation isn't happening when we're 5 and 6, right? And seeing little kiddos that are masturbating and not really, how do we explain that? How do we talk about it? It's hard, right? And then kids go through puberty and then we're not talking, right? So it starts at home, but I don't think we have enough of the infrastructure anywhere to be able to teach kids on an appropriate level per age grade. Because really that's what we would need. We would need a K through 12 program that would be adoptable to most places that would teach kind of some of those basic things like consent. Um, and the reason I brought up my PhD was like that was one of the things I really wanted to do was try to build a curriculum for K through 12 sex education that would be even for a conservative rural state, something that they would be willing to adopt. But it's it's hard when you're missing even then, but if it's not being reinforced at home, you're still not going to have 100% of that space to help manage but you're 100% correct. I think we would see a significant reduction in sexual dysfunction if we were having more conversations like that.
It's been great conversation. Thank you all again. Been really engaged and really great. Elise, you are wonderful. And it's always a pleasure to hear you speak.
Thanks,
You're
Lauren.
fun. Yeah. And it's such, like Anita said in the chat, it's such important work that you do. And,
Thanks.
it's so needed. As someone who grew up in this state, it's, as I'm sure a lot of us did, you can't, our legislature even today, yeah, like you said, you just don't hear it. So
Right.
it's really important. We appreciate you.
Oh,
Any
thanks, guys.
other any other questions or comments for Elise? Okay. Well, I will be sending out a PDF of her slides so you can use them in your practice, the tools that she gave you all, and ask her, other questions if they come up. And I am going to put a link in the chat for you to sign up for our next session if you are interested, which is on September 24th, the Tuesday at noon. And it will be focused on how you deal with your cancer patients in your primary care setting when they come in ill and what are the complexities that you have to consider that way. And that's Dr. Tina Botnagar. So, if you please register for that, and we hope to see you there. Anything else that you have, feel free to reach out with any questions. The CME link is in the chat. Again, that's pending, but we'll get back to you as soon as we have any more information on that, but you can go ahead and fill out the form for us. So again, thank you to Elise. Thank you to all of you, and hope you have a great rest of your week.
Thank you, everyone.
Thank
Thank
you.
you.
Thank you.
Bye.